Okay, so this is the second part of this talk. We're going to switch gears to talking about errors in decision making, and we'll use polypharmacy as an example. So errors in decision making can be of two types. We can either make the wrong diagnosis, or having made the correct diagnosis, we may choose the wrong kind of a treatment. Polypharmacy goes in the second category. Why do errors in decision making happen? Well, it's the same reason as always. It's a problem with the system fundamentally. Here's an example of polypharmacy. So often we use medications where the side effects are worse than the disease. Here's another example. Sometimes medication is no better than nothing. What is the definition of polypharmacy? Well, there's an old definition which is based on the number of medications. So if a person was taking 5 or more medications, that was considered polypharmacy. This definition is no longer used because, first of all, many patients need multiple medications, and therefore to use this arbitrary cutoff is meaningless. The other reason is that even if a person takes only one medication, that may still be polypharmacy. If that person didn't need that medication, then if it's too many for that patient, then it's polypharmacy. So the absolute number really doesn't matter. What matters is this. Is it inappropriate use of medications? If it's inappropriate use of medications, then it's polypharmacy. Here are some examples. Medications without a valid indication. That's definitely polypharmacy. If you don't need the medication, then you shouldn't be on it. Inappropriate dosing, too high or too low. If it's too high, I think that's intuitive. If it's too low, then it means you're exposing the patient to risk, but they're not at a sufficient dose to have any therapeutic effect, and so that's inappropriate. The third case, medications used to treat the side effects of other medications. This is referred to as the iatrogenic cascade. This we'll come back to. It's very important. Potentially inappropriate medications for older adults. This is the Beers criteria, which we'll also come back to. Why does polypharmacy happen? Well, there are lots of reasons, which we'll quickly try to go over. Some patients have lots of symptoms, and as doctors we like to treat symptoms, so we keep giving them more medications. Then there are patients who have multiple doctors who are all kind of adding ingredients to the mix. Then there's habit-forming drugs. Then there's the fact that prescriptions require less time than explanations. It's much easier to write a prescription for a PPI than it is to explain to a patient with GERD that they need to change their diet. Then there's iatrogenic cascade, which I said we'll come back to later. Then there's failure to optimize medications before starting new medications. There's failure to streamline medication. There's failure to evaluate effectiveness. Is the medicine working? If not, we should probably stop it. Has the problem resolved? If so, we should stop it. And there's diagnostic errors, as you can see. And there are other patient factors. But the bottom line is that polypharmacy is a systems issue. In other words, all of the reasons that were listed on the previous slides really have systemic causes at their root. As you can see, there's limited training, there's limited time. It takes time to provide medication review and careful use of medications. It's very quick to just keep adding new medications and not think about it. But we have time constraints on us, so it's not that we're bad doctors and when we keep adding medications without thought. It's just that we have a limited time, and therefore there's a pressure on us to behave in a certain way, and that's a system problem. Fragmentation and lack of medication tracking systems. These are problems that result in us not knowing what medications the patient is already on. Therefore that leads to poor decisions about what we should add. Lack of decision support is another one to be aware of, that there are these systems available to help us make decisions by providing information about drug interactions and warnings about inappropriate medications if a patient is elderly, for example, but we typically don't use those kinds of systems. Who is affected by polypharmacy? Well, any patient can be affected, but older adults are more often affected. And polypharmacy is often discussed in the context of geriatrics because of the fact that older patients tend to be on more medications because they have more problems, plus they're more susceptible to the effects of medications because they have comorbidities, they have sensory, cognitive, and physical impairment. That means they have less reserve. So a young person like yourselves could tolerate a medication that makes them a little drowsy because you have plenty of reserve, but somebody who has limited reserve, that same drug might have a much more profound effect. There's changes in metabolism, including renal, hepatic, and changes in distribution between water, fat, and decreased muscle mass, leading to changes in levels of various kinds of drugs as listed here, which requires us in general to use lower doses. What are the consequences of polypharmacy? Well, polypharmacy has lots of bad effects, which are listed here. The most serious two that I would point out are delirium, which is common, particularly with benzodiazepines and particularly with anticholinergic drugs, and falls, which are also due to the same drugs causing sedation. And falls are a major problem in the elderly, leading to hip fractures and decreased life expectancy. So let's think about an example patient. Here's a patient who's an elderly man with hypertension and CHF, and he's on various medications, and you're seeing him in the office for follow-up for the CHF exacerbation. He's currently asymptomatic, no symptoms of CHF. Blood pressure is on the high side, but the exam is normal. The CHF is resolved, there's no edema, there's no crackles in the lungs or elevated JVD. So the patient is now presenting with this elevated blood pressure, and the question is, what should you do? One possibility is to say, well, he needs more medicine. Clearly his blood pressure is too high on this regimen, so we need to increase the medicine. If that's what you want to do, then I would suggest that you stop and think for a minute, and instead of that you should ask the patient some questions. Normally we do this as a role play, but in this context I would ask you just to pause for a second and think about what would you ask the patient in this situation. Okay, well, if you had asked some detailed questions, you would have found out some interesting things. If you take a detailed diet history and ask specifically about salt intake, you'll find out that the patient likes to eat a lot of sausages. Of course, if you just ask, do you eat salt, or do you add salt to your food, the patient will probably say no. But if you're aware that certain kinds of processed foods, such as sausages and other processed meats and canned foods, etc., they contain a lot of salt, if you ask about those things specifically, you'll find out useful information. Excuse me. Furthermore, you'll find out that sometimes I skip the Lasix because of accidents, and sometimes the patient skips the metoprolol because of ED, and also that the patient takes over-the-counter non-steroidals. So now you have helpful information that tells you two things. First of all, it tells you why the patient had a CHF exacerbation, most probably because of excessive salt intake from all the sausages, plus NSAID use, likely causing fluid retention, which contributes to CHF exacerbation, plus skipping Lasix also could lead to CHF exacerbation. And we also know why the patient's blood pressure was out of control, again because of salt intake, because of missed doses of metoprolol, and also NSAIDs, in addition to causing fluid retention, also cause elevated blood pressure. So now we know why the patient had a CHF exacerbation and why his blood pressure is elevated. Now we know what to do to fix those things. We don't need to increase the Lasix to prevent CHF exacerbation. We don't need to increase the metoprolol to lower the blood pressure. What we need to do is work on these lifestyle issues. We need to lower the salt intake, we need to avoid non-steroidals, and we need to figure out what to do about the Lasix and metoprolol compliance. Either that we need to change to other drugs that don't cause these side effects, or we need to help the patient somehow overcome these problems. So let's pause here. We're going to talk about some principles for safe prescribing for older adults, but we're going to do that in the next part.